Hey, today I'll be answering questions you sent in to me across OncLive's social media platforms. I'm Dr. Joshua Richter, and this is Ask Me Anything with OncLive. Let's check out Twitter X. Rahul Banerjee asks, looking forward to this, Josh. Since you've used SIVO on trial more than many of us, where do you see FcRH5 fitting into the future as BCMA and GPRC5D rush to first line and second line? All right, so this is a really great question because cevostamab is a really fascinating new target in the world of myeloma, and I think we've become very in tune to targets like BCMA and GPRC5D across a variety of platforms, including bispecific antibodies, CAR-Ts, and now with the reapproval of belantamab mafodotin, BCMA is coming back as an antibody-drug conjugate. Cevostamab is currently being evaluated as an FcRH5-CD3 bispecific antibody and has shown impressive response rates even with fixed-duration therapy in relapsed refractory myeloma. Where I see this really entering big is with the current registrational trial CEVOLUTION, looking at the combination of cevostamab and pomalidomide in 1 to 3 prior lines of therapy. I think this is going to be an excellent option for patients who receive BCMA bispecifics or BCMA CAR-Ts in the front line in the future. We'll have this as an next line of therapy. And I'm looking forward to some future trials with cevostamab in combinations in the frontline setting where hopefully we can give fixed duration, achieve deep and durable remissions, and potentially cure for some of our patients with myeloma. All right, so I really have to answer, Rahul Banerjee asked me for a dad joke. So the dad joke that I most love to tell is, 2 peanuts were on the subway, one of them was assaulted. I'm sorry. Chris Ryan asks, is there a novel drug class in the myeloma space that you're most excited by? Absolutely. I am really excited by trispecific antibodies. I think CAR-Ts have become a really exciting new modality, but we need to understand that they're not available for many patients, either because of access issues or because of comorbidities. Whereas bispecifics have become available essentially anywhere antibody therapy can be given, and trispecifics are simply the next iteration of that. There's a couple of trispecific antibody drugs that are currently in clinical trial, including rimantamig, the GPRC5D BCMA CD3 trispecific, with some really impressive response rates, including data recently presented by Rakesh Popat showing a 100% response rate in relapsed refractory myeloma. What I love about these therapies is that they're available anywhere because they're off the shelf. They can be given at any time. And again, by the fact that we can hit both of those key targets all at once, maybe we can eradicate so much myeloma that we never need to attack it again and either achieve extremely durable remissions or, fingers crossed, one-day cure. Chris Ryan also asks, what is your go-to Pluto TV channel? I love Pluto TV. I'm not going to lie. It's really one of my favorites. And lately, if you go down all the way to the sci-fi, they have all of the Star Trek The Next Generation on repeat. And I could literally watch that on end without stopping. Big fan of the Q episodes, so really that's what I'm watching mostly lately. Patrick White asks, okay, cool tech, but let's not oversimplify immune risks. For those of us dealing with dysregulation, what's the plan? Still fascinating stuff. So I think this is something that really needs to be addressed when it comes to modern-day therapy with myeloma. We are giving what we consider to be very focused treatment in killing the plasma cells, but we also have to recognize that once you start attacking immune cells, immune dysregulation on a variety of scales becomes the main toxicity, both overactivating and underactivating the immune system. What I mean by that is underactivating is where we kill so much of the immune system that patients have to deal with infections. This is where prophylactic IVIG, prophylactic anti-infectives, and keeping up with your vaccination schedule is absolutely key to preventing infections. On the other end of the spectrum is overactive immune system, things like T-cell redirection leading to macrophage activation syndrome or even hemophagocytic lymphohistiocytosis. We see these with a variety of our therapies. So at the end of the day, what it really comes down to is aiming for Goldilocks. We don't want the immune system too hot, where it causes things like MAS and HLH. We don't want it so cold that you're getting infection, but really trying to target it that we thread the needle and keep you right in that Goldilocks zone where we kill as much of the immune bad cells as possible, keep as much of the good immune system intact, and really try to prevent any of these long-term toxicities. All right, next question. What are views concerning IMiDs for the elderly patient? In Sweden, there's an ongoing debate whether it is safe or not, and in Denmark, it has been restricted because of too high toxicity. I think this is a really critical question because we all like to think that oral oncolytics are safe, and they do have some toxicities, and we do have to pay that cost for pills at home. When it comes to IMiDs, I think there's a few key things to think about when it comes to giving them to some of our older and frailer patients. One is dosing. I think we all get very locked into lenalidomide dosing at 25 milligrams. I have patients on 10. I have patients on 5, and I even have on 2.5. And even sometimes, instead of dosing it 3 weeks on, 1 week off, actually do it every other day for those 3 weeks, or even giving 3 weeks on and 2 weeks off. Giving older patients who may have an older body in general, an older bone marrow, which may have not quite as much reserve, it's key to give them the proper breaks and proper dosing. So I think we can thread the needle and take advantage of the myeloma cell kill we get with IMiDs, but dosing appropriately. The other key thing is dosing that dexamethasone appropriately with your IMiDs. Hamza Hashmi asked this: how much do we know about FcRH5 as a target? Is it lost or downregulated as easily as GPRC5D? Are poor responses with SIVO post-BCMA progression related to exhausted T cells? Would MESI plus SIVO be better to recharge a T cell? Soon BCMA refractory will be defining new functional high risk in myeloma. I think this is a really important question. So we do probably know the most about BCMA, a little bit less about GPRC5D, and definitely less about FcRH5 as a target. One of the things we do know is about soluble forms, and what I mean is that with BCMA, we recognize that there is an enzyme called gamma secretase, which clips the BCMA off the malignant plasma cells and allows BCMA to circulate in the blood, the so-called soluble BCMA. And we can actually use levels of soluble BCMA to predict responses to these therapies, and in fact, predict responses to other targeted therapies, including GPRC5D and FcRH5. When it comes to GPRC5D, there is no soluble form, but there is a soluble version of FcRH5. We recognize that we can actually measure these levels in the blood, and this may allow us to predict responses to SIVO or similar therapies that target FcRH5 in the future. I think Hamza's suggestion of using a CELMoD or an IMiD to boost T-cell responses along with a bispecific antibody, especially in a post-BCMA therapy patient, is probably the right way to go. Andrew Gordon asks, how do you treat a patient with CNS myeloma at relapse but no bone marrow involvement? These are some of the hardest questions that we face because this is when myeloma is really not behaving like it's supposed to. So to me, I think this is a very clear case where we need to think about what I call sterilizing the CNS space. And what I mean by that is oftentimes when we get CNS myeloma, which for the most part is going to be leptomeningeal involvement, far less commonly to be parenchymal disease, we want to give aggressive therapy to sterilize this, and I generally feel that giving intrathecal therapy is really mostly a temporizing factor. To me, we need to get them to something like cranial spinal irradiation, or CSI. Now, traditionally, that's a fairly toxic regimen. However, with some of the newer modalities like proton beam CSI, we're able to provide sterilization approaches to the CNS with relatively very well tolerated toxicity profile. The only caveat is that it takes about 3 to 4 weeks to simulate. In the meantime, I tend to give things like selinexor, pomalidomide, and dexamethasone as a bridging regimen because in that scenario, all 3 drugs penetrate the blood-brain barrier and allow us to control the CNS along the way. But ultimately, I do like to get them to the sterilization approach with proton beam CSI, and especially for patients with no other disease in the bone marrow, this may be a way to put them into a deep and durable remission. All right, let's take a look at LinkedIn. So Riley Kandel says, what are some optimal risk stratification strategies for patients with smoldering myeloma? And the follow-up, as a former NYC resident, I gotta know, what's your favorite part about New York City and what's your favorite restaurant in the city? All right, let's talk about optimal risk stratification strategies for patients with smoldering myeloma. There's a ton out there. And to me, they all fall short. To me, the best strategy is time. And this is something that's not talked about a lot. But to me, I want to see what has happened over the last 3 months, 6 months, 12 months. That's the biggest litmus test for whether or not you're going to progress or not. So if over the last 3 months, 6 months, 12 months, your paraprotein has remained stable, that to me is more important than any 2-20-20 or the Pathema guidelines or circulating tumor cells, because that tells me that your immune system is already doing the right job and holding this at bay. Because myeloma is a movie, it's not a snapshot. What happens over time is critical. The other thing that I like to use is looking for immunopoiesis, meaning if you have an IgG subtype, I want to look at what the IgA and IgM are doing. If they're suppressed, that tends to be a little more predictive of a smoldering myeloma that's going to cause trouble in the future. So as far as New York City restaurants, right now my favorite restaurant is Ivan Ramen. If you go downtown to Ivan Ramen, it's some of the best ramen you'll ever have. It's one of only 2 Michelin-starred ramen restaurants in New York City. They have an amazing soundtrack if you like old school hip hop and like 80s, 90s rock and pop. So great vibe, really great ramen, especially on those cold New York winters. Other favorite places? This is really tough. All right. Other favorite places? I got one more I went to this weekend with my kids. Kaiten Sushi. Yes, I pronounced that correctly. It's Kaiten Sushi. It's actually the only conveyor belt sushi restaurant in New York. So if you really wish you were sitting in Tokyo at an amazing conveyor belt sushi restaurant, go to Kaiten Sushi in Nomad. Can't be beat. Let's check out Instagram. So next question says, hi, Dr. Richter, what's one question or area of uncertainty you're hoping to see addressed through a data readout or otherwise at the upcoming EHA meeting? So the European Hematology Association meeting, which is coming up, is really going to focus on a lot of our newer therapies and our immune therapies. And one question that I think we all are dying to know is, how do we sequence? So I think the brass ring in myeloma that I'm hoping we start to get some clarity on is, we have all these amazing therapies. How do we sequence them to optimize outcomes for our patients? So one of my amazing colleagues, Dr. Garbakh-Kar, asked, Dr. Richter, can you shed some insight on decisions between bispecifics and CAR-T as they are both now approved in early relapse? Absolutely. So we literally have the vanilla and the chocolate, the Fender and the Gibson, the Chevy and the Ford. We have 2 amazing options at early relapse. Which ones do we like better? It really comes down to the patient themselves. However, there are some key factors we like to think about when deciding between these 2 modalities in early relapse. One is the general age and health of the patient. We kind of have data so far that says if you can give CAR-T and a bispecific, better to give CAR-T first, then bispecific later. So if we have a younger patient where we may want to give many of these therapies throughout their journey, I try to give a CAR-T at early relapse. If they're a little bit older and frailer and need something that's a little more titratable, I tend to go with bispecific. Though some data that's going to be read out in the upcoming meetings is looking at the role of bispecifics in CD38 refractory patients. And we're going to see this with the Majestic-9 readout. And one of the things that we've seen with CARTITUDE-4 is that patients who are refractory to CD38 probably don't do quite as well with CAR-T, but they still do amazingly well with bispecifics. So to me, if you have a patient who's refractory to a drug like daratumumab or isatuximab, and they're progressing rapidly, a bispecific antibody may be your better choice at early relapse. So our next question says, do you think a vaccine may become a treatment for myeloma? Do you know of any being developed? Again, I think this is an absolutely amazing question, because that's what we're really going for in the cancer world. Is right now we're dealing not with healthcare but with sick care. We deal with it once it causes trouble. Can we do something ahead of time to try to prevent it? There are a number of vaccines that are being looked at in myeloma, and I actually took part in one of these trials many years ago that we looked at giving a vaccine along with a short course of IMiD-based therapy to people with smoldering myeloma to prevent them from becoming full-blown symptomatic myeloma patients with some interesting outcomes. So right now there are a number of vaccine trials, a lot of them being done ex-US in places like Israel, where they're actually looking to give patients who have earlier forms of the disease, like MGUS or smoldering myeloma, some type of immune-based vaccine to prevent them from evolving into having symptomatic disease. not quite ready for prime time, but we're all really excited to look at this area as an area where we may be able to prevent patients from ever developing the symptomatic cancer. So let's switch over to Facebook. So Ashling Warner says, if you're headed to EHA, what are you most excited to do in Stockholm? Okay, I have to admit, I am a guitar pedal addict. I'm what's called a tone chaser. So I love these little boxes, fuzz boxes, distortion boxes. They're literally my passion. So anytime I go to a city, I like to look ahead of time to find out the really great guitar pedal shops. They have one in Stockholm that's called TGT11. That stands for These Go to 11. And if you already know what that's a reference to, we can be friends. It's a reference to one of the greatest films of all time, This is Spinal Tap. And there's actually a pedal store in Stockholm that is named after Spinal Tap, and I cannot wait to go and try all of their guitar pedals. Yes, while I'm there, I will go to meetings about myeloma, I will learn about myeloma, but really more excited to go to TGT11. Next question, what are some of the most important considerations regarding the implementation of outpatient therapy administration for myeloma? I think what we're really aiming at here is outpatient administration for bispecific antibodies. Because when we first started giving bispecifics, we admitted everyone to the hospital. But that step-up period could be a week long in some cases. So one of the biggest things we're looking for to implement these in the outpatient setting are a few factors. One, prophylactic tocilizumab. If you look at the original studies, the rates of CRS without prophylactic tocilizumab for the different antibodies range between about 50 and 70%. In our hospital, giving prophylactic tocilizumab, we're under 10%, and it does not impact the response rate. So we're really excited about that. The other is we send patients home with what we call pocket dex, which means if they call us in the middle of the night and it's clear that they're having a delayed CRS event, we tell them to take the dexamethasone. This is because if you tell them to go to the emergency room, even the best emergency room, the first thing they're going to see is a cancer patient with fever, and they'll give them antibiotics. It may be very prolonged until they give them steroids. But this way, the patient already has steroids to be given. The other is who gets that first call. So many of us work at teaching hospitals. So if that first call is going to a first-day fellow or first-day resident, they need to be educated on how to deal with the subtle toxicities of bispecifics. So to me, those are the real big ways to optimize outpatient administration of bispecific antibodies. Thank you so much for participating. This has been Ask Me Anything with OncLive. My name is Dr. Joshua Richter. I'll see you at the next myeloma event.